remember kind of from early on in my Zen training, there was a saying that you needed three things to be a Zen student. You needed great faith, you needed great doubt, and you needed great perseverance. And I think all of us who are seasoned clinicians have all three of those, that you feel pretty confident that you understand what's going on. There's always this room for doubt and uncertainty. And then you need to stick with it. You need to remain engaged and involved because things change.
Namaste. You're listening to the Savannah Podcast. Join us on an exploration of Eastern spirituality, yoga philosophy, and conscious living for the new age. This podcast is a production of SavannahSpirit.com, where you can find a large selection of Om and yoga clothing, spiritual jewelry, and unique fair trade gifts from the Far East. Now here's your host, Ashton Sabo.
Greetings, everyone. Welcome to the Savannah Podcast. We've got another great show in store for today. We're going to be talking about mindfulness, but in particular, mindfulness in medicine. Our guest is Doctor Ronald Epstein. He is a practicing family physician, a professor of family medicine, psychiatry, and oncology at the University of Rochester School of Medicine and Dentistry in New York State. He's an internationally recognized educator, writer, and researcher whose landmark article, Mindful Practice, published in the Journal of American Medical Association, has revolutionized physicians' view of their work. He has been named one of America's best doctors every year since 1998 by U.S. News and World Report, and his new book, Attending Medicine, Mindfulness and Humanity, was recently published through Simon & Schuster. Really excited to have him on the show today. Dr. Epstein, welcome.
I'm really glad to be here.
So you originally weren't going on the path of medicine. You actually tell a story of how you spent a few months in a Zen center, which seemed to very much influence your approach to medicine later on. But it wasn't until you got sick in India as well. You and I both share the common experience of kidney stones, which perhaps we could talk about as well. But that experience as well kind of seemed to draw you into wanting to get into medicine. I was wondering if you could tell us a little bit about your background, your journey into medicine, but most particularly how mindfulness and this idea really has influenced you throughout the work that you do.
Great. Well, you asked a lot of questions, so I'll try to start from the beginning. The truth is that as a kid, I wanted to be a doctor, and then when I was a teenager, I got interested in lots of other things, including Zen Buddhism, and I was also a performing musician. So, but it was really in my early 20s when I was trying to think about what would give me the greatest sense of purpose in life that I began re-examining why I might want to become a doctor again. And you're right, I did have a couple of personal experiences. The first of which was a kind of ironic one. I was in India, in Benares, visiting a friend who was studying music there, and borrowed a bicycle and rode out to Sarnath. Now, Sarnath is the place where the Buddha gave his first discourse, and that discourse was about suffering. And so I'd ridden out there. It was a hot day, and there was this guy squeezing oranges, and the orange juice looked so good. I knew about health and all this stuff, but it looked like he was squeezing the oranges right into a glass, so there wasn't any water. And so I bought a glass of orange juice, drank it up, and visited the deer park where the Buddha had given his first lecture, and then got on the bike and got home. And I'm not sure if it was hours or a day or so, but I was pretty sick at that point, and typhoid was endemic, and I was informed by my friends that, in fact, orange juice vendors were notorious for cutting the orange juice surreptitiously with water. So there I had gulped down lots of water with all sorts of imaginable organisms in it, including possibly typhoid, which was kind of a frightening thing. And it turned out that they took me to the clinic, and in fact, the lab workers in the clinic were on strike. So I actually had to go to the hospital. Got to the hospital, and as was the case in third world countries in those days, the hospital was overflowing with, the wards, were one bed next to the next, families camped out next to the bed, and the outpatient clinic where I was, people were brought there sometimes, having walked for days or being carried for days from remote villages in desperate states of health. And here I was, 23 years old, never having witnessed anything like that. So I did not want to join their ranks and appear that I was at the verge of death. But there were a lot of people who were. And just all of this was somewhat surreal because, when you read the life of the Buddha, in fact, he was, raised in this very sheltered environment. He was a prince and then went out into the world and saw various forms of suffering. And here, I went to exactly the same place where he witnessed these same things, which 2,500 years later were probably not very different. Mm-hmm. So for me, that woke me up. It made me frightened. It made me curious also about, what healthcare had in store for me. And then a few weeks later, or actually not even, a couple of weeks later after I'd returned, I was living in Amsterdam studying music. Probably precipitated by the dehydration that I had from this episode. I was woken up at 5 a.m. With a kidney stone. I kind of knew what it was because it was the right location and I had friends who had had them. But boy, it was a very different healthcare experience. The academic hospital in Amsterdam was anything but teeming. In fact, it was kind of deserted, sterile. Everything was white and lonely. And I didn't know what was going to happen and was facing, again, this same sense of uncertainty. Previous to that, I felt pretty invincible, as most 23-year-olds do, and pretty invulnerable. But for me, it was a wake-up call that not only suffering existed in the world, but also existed in me.
Well, and your book, I want to thank you for your book on many levels, in particular because, speaking of the kidney stones, when I had my kidney stones, my experience with my doctor was not a pleasant one, and I have held on to some anger because of the way that I was treated through the whole situation, everything else, and your book really gives a human side to doctors, which I really appreciate, where it's like, oh, you know what? They're all human beings. They're in a lot of really tough situations all the time. They've got to make tough decisions. So that actually helped me quite a bit, which is not even necessarily the main theme of your book, but it definitely helped me. Now, your book, it seems to be written very much for healthcare practitioners and doctors, or at least sort of addressed to them. But I think the messages in it are quite universal to everybody. I was wondering if you could talk a little bit just about the broad scope of what you see as a big challenge or a problem in the way that Western medicine is being taught and practiced right now, because your book seems to kind of cover this basic idea that something perhaps is missing quite significantly from how we're practicing medicine right now.
Well, I want to address two issues that you brought up. One is that I wrote the book not only for doctors and health professionals, but also kind of as an example of how you can bring mindfulness into your work life no matter what you do. Mm-hmm. So if you're a radio interviewer, if you're an air traffic controller, if you're a policeman, whatever it is that you do, if it involves people and it involves high-risk situations, then being mindful is going to be useful and helpful in some way, not only in the accuracy of what you do, but also the satisfaction you derive from your work. So that's really why I wrote the book, is to use my experience as a health professional as just one of many possible examples. And I'm hoping that people, even those who haven't had a lot of contact with healthcare, can resonate with that.
And I think they will. I really do believe that even though the stories themselves take place in that field, the messages are universal, and you're always bringing in, I mean, it's a medical book, but you're quoting Rumi throughout there and all kinds of other wonderful things and Zen stories. So it's very accessible still. I still feel so. I appreciate that.
My philosophical hero when I was younger was Walt Whitman, the poet. Mm-hmm. And he really extolled the commonness of human experience. And at one point in his long poem, he said, I contain multitudes. And I think that's true of all of us, that we can really relate to each other's experiences and really try to understand what it is that's most important in life.
Mm-hmm. So going back to that question, though, of what do you see as the thing that's perhaps missing, or the elephant in the room, so to speak, in the way that students of medicine are being taught and how doctors themselves are practicing, and some of the concerns that you have that got you to write the book as well.
My training as a physician didn't involve very much in the way of introspection. It didn't involve understanding how my own mind worked. And it's not just from an emotional standpoint, it's also from a problem-solving standpoint. Clinicians, like everybody, tend to observe some things and ignore others. They tend to pay more attention to things that they consider relevant, tend to ignore those things that seem less relevant. I'll just give you an example. If someone comes to me and says they have a pain in their elbow and it's right here, this specific location, and it hurts when they move their wrist in a particular way, that's a much easier problem for me to solve than if someone says, I hurt all over. Okay? And I have patients who do both. And doctors are kind of trained to focus on the specific as opposed to the general. And it's just the structure of American medicine. Now, I've also studied Chinese medicine. And Chinese medicine, when you say you hurt all over, that doesn't bother Chinese physicians. They may have more trouble with the elbow problem or something else, but it's just because where you choose to place your focus. I've studied communication between patients and oncologists. Oncologists tend to focus a lot on physical symptoms and on scans, but when patients say that they're fearful or they're worried, that tends to kind of fly right by them because their training doesn't equip them to deal with emotional issues as readily. So this thing that I call mindfulness is really an attentiveness to those things that you're naturally keyed into, but also curiosity about those things that may be a little bit outside of your envelope. And often those things that are outside your envelope are the most important cues as to what's going on with the patient.
You actually quote a physician teacher, William Osler, in your book, saying that we miss more by not seeing than by not knowing. And as a yoga teacher, I really appreciate that too, because it says, like, look, you can have all the knowledge in the world, but if you're not present, what good is it? What does it matter?
Exactly. So William Osler was a British-Canadian physician who is kind of viewed as one of the forefathers or foreparents, if you will, of modern medicine. And he brought to medicine the clinical approach. So before that, people would read textbooks and listen to patients' concerns and kind of put them in a category. And Osler brought the idea of bedside rounds, where people would gather at a patient's bedside and all observe the patient together. And this was a radical idea in the 19th century. You know, it's now perfectly ordinary. But he was a fabulous observer of humans. And I think he was absolutely right, because gaining the knowledge that you need for being a good doctor is not all that difficult. It takes a lot of work. It takes a lot of perseverance. You don't have to be that smart. You just have to have a good memory and a strong will. But the thing that makes you a good doctor is your ability to see subtle changes. So I'll give you an example. When any good pediatrician will say, you know, when a kid comes into the office, that kid looks sick or that kid doesn't look sick. How do they learn that? How do they, unpack that? Well, maybe it's the kid's a little pale, they're not moving as much, they're breathing a little faster. There might be elements, but if you try to add up all those elements, it still doesn't add up to this intuitive sense that the child looks sick. Now, if you don't pay attention to that intuition, you're going to miss a lot. Now, clearly you need to know all of the 10,000 things that could possibly happen to a young child and the medications that you might use to treat that and what have you. But if you don't have that intuitive side and also that kind of rock-solid knowledge side, but the intuitive side is really what guides what you look at, okay? So it's a choice of where you place your attention. There was a description by Henry James of an exemplary physician. And he described this, again, the late 19th century, but said he put this empty cup of attention between him and his patient. And I really like that. It's almost Zen, because if your cup is full, if you're full of your own ideas and full of your own preconceptions about what's going on, you stop looking. You stop seeing what's actually there.
In your book, you even mentioned that Zen story of the professor coming to the Zen master who sit down and starts talking about philosophy, and the professor's just talking. And so the Zen master is pouring his tea and just keeps pouring, and it's overflowing. And the professor's like, "Hey, what are you doing?" And he's like, "Well, you're like this cup. You're just overflowing with everything. What room is there for anything to come in?" So yeah, I love that analogy too of the empty cup in between.
I think, and for example, one of my mentors, we were kind of rounding on patients, and this was a number of years ago, and he came out of the room and said, what did you observe was missing? And in fact, thinking about it, the room was absolutely stark. There were no greeting cards, there were no flowers, there was no evidence that any other human had visited this patient. And just being attentive to what's there and what's not there gives you all sorts of cues and about what that patient might need.
And you're talking about intuition, and I feel that that's a kind of it can, at least in this field of health, kind of go hand in hand with ideas of compassion. And compassion is something that you also write about in your book. And you even say, for compassion to emerge, we have to create the right conditions. How do you define compassion in this sense, and what are the conditions that actually help it emerge in people?
I would define compassion as having three components. One is observing someone else's distress. And that's not always as straightforward as you might think, because sometimes people express their distress in many different ways. I had a patient, for example, who came in and said, "I'm thinking about taking early retirement." Well, this was an engineer, not a very emotional kind of person. He had cancer. The cancer was curable. But just saying that made me realize something's changed in this guy. Maybe he thinks he's going to die. Maybe he's frightened about something. So first is recognition. The second is resonating with that. Now, that's hard to do. Imagine if you're seeing 40 patients in a day, each one of whom is suffering in some different way, and then you resonate with that suffering. If you don't have a certain amount of resilience and boundaries, that can be exhausting. So it's resonating just to the right degree. Okay, you can't fall to pieces every time a patient gets sick, or even if a patient dies, you have to go on. So it's resonating just enough. And then the third part is acting on behalf of that person to reduce their suffering. But that means knowing what that person really needs. Do they just need a listening ear? Do they need a medication? Do they need you to talk to a family member so that they actually legitimate that person's illness? Just say that this person's really sick. You need to pay attention to. So what is it? And so you have to ask in order to be compassionate. You can't assume that the patient is coming in just because they want a pill. Actually, very often people don't. They just want to be understood. So I believe that compassion can be taught. So recognizing suffering, well, that's fairly straightforward. You learn how to ask. What bothers you the most? What frightens you the most? The resonating piece, I think that is an interior education of just trying to learn how you respond to other people's suffering, and not to turn it off, but just to modulate it enough so you can tolerate it enough to understand. And so it means not turning away, it means turning towards suffering. And that's something that I believe that we can teach. And in a lot of wisdom traditions, both from the East and the West, a lot of it focuses on really recognizing and internalizing some of that sense of suffering. Ironically speaking, actually it makes you feel better when you understand that, but I'll talk about that in a minute. The third part, doing something on someone's behalf, that always makes us feel good, We know from psychological research that giving a gift makes you feel better about yourself than receiving a gift. And so here, the gift is my presence. It's listening. And it doesn't have to be a lot. It can just be 30 seconds of letting the patient talk and then saying, "Now I understand."
In a practice of compassion, I mean, you mentioned that it's something that can be taught. What's actually happening inside somebody in terms of their chemistry and their brain when they're acting compassionately or practicing compassion?
Well, First of all, this is really interesting research because compassion wasn't on the radar screen for psychologists until very, very recently. And what we're learning is that it's not just humans who are compassionate. There are other species who are as well. They act on behalf of others without any extrinsic reward. They don't gain from having done so. We know from experimental psychology, where they do experiments with people in a psych lab, that parts of the brain that produce dopamine get activated when you're compassionate, when you act on someone else's behalf. Now, dopamine is the same chemical, as we call it the feel-good hormone. It's the same thing that's released when you drink a cup of coffee or use cocaine, but this is natural, and obviously in smaller doses. But the parts of the brain that trigger what are called the reward circuits are activated. So when you say that giving is its own reward, it's actually true biochemically that our brains change. The cutting edge of neuroscience is whether not only it causes release of more chemicals, but does it produce more receptors for those chemicals on nerve cells? So even, let's say you produce the same amount of dopamine, will it have an enhanced effect in someone who practices being compassionate? And it seems that might be the case. And one thing that we do know, this is from animal studies, is that if you're in a supportive social environment, if you feel that others care about you, then you'll actually grow more dopamine receptors and experience greater reward from being compassionate yourself.
Wow.
So think about this. Healthcare environments are not the friendliest places. Okay? If you add, there was a study of doctors who made mistakes, and they were asked if they felt that their healthcare environment was supportive after they made an error. About 10% said yes, which means 90% didn't. So if you're working in an environment that's fundamentally unsupportive, you're less likely to experience as great a reward from being compassionate. But if you're working in a place that is supportive, then it will promote other people within the organization being more compassionate.
Is this a change that you feel needs to happen sort of systemically, or does it start individually? Like, do we need to say, well, we need to bring more compassion into our workplaces, or does it really start by each individual taking personal responsibility and practicing mindfulness and creating a practice of compassion itself?
I think that you need both. That at a certain point, environments become so toxic that it's very difficult to see the effects of one's own work. And I think healthcare has gotten worse in that regard. It's much more production-oriented. Physicians and other healthcare workers feel more that they're just cogs in a machine. They feel like they're widgets. Their work is fragmented. They spend more time looking at a computer screen than they do with patients. So those things will erode your sense of well-being and feeling that the institution that you're working in really is supporting what's most important. On the other hand, this is not going to change quickly. And healthcare, in my view, will never be supportive enough to mean that you don't have to work on yourself. Healthcare has always been difficult. Actually, a lot of work has been very difficult, not just in healthcare. And so if you're equipped to be able to notice and be curious, be attentive, be present, if you learn those as skills, that's going to serve you well regardless of the nature of the environment you're working in.
Now, in terms of learning how to be more attentive, you talk about exercise that you learned in college called the 3 days of red. I always like having our listeners get some practical stuff. I was wondering if you could share that exercise with us and just give us a quick idea of how this can help us be more mindful of our environment.
Yeah. Well, it started out being called 3 days of red, but with busy healthcare practitioners, it usually ends up being 15 minutes of red. The exercise is really simple, and I'd encourage you to try it yourself because it really changes the way you look at the world. Set aside let's say 15 minutes, and decide that you're going to write down everything red that you see, everything that's the color red. If you're colorblind, choose another color. It doesn't have to be red. But also pay attention to what's going on in your own mind. So I usually do this as a group exercise, and then we debrief afterwards. So people, and do it silently, and have you can write it on your iPad or on a piece of paper, whatever you want to do. And people wander around in their environment, and then when we debrief, people predictably say a few things. One is that they notice things that they've never noticed before in the world. They pass this particular, painting or person or place, and they never noticed the color scheme. They also notice that they find things that are red more interesting than things that are not red. They begin to wonder, how red does it have to be called red? The depth of the hue, the nuances of red, and other things begin to fade into the background. Then people become, that happens to everyone, but then people differentiate. For example, some people get competitive. They say, well, am I getting more red things than other people? Or am I getting the right red things? Or am I getting the most unusual red thing? And then some people get bored, and that will, even in 15 minutes, some people get bored with this. Some people wonder, how they can apply this to other parts of their lives. How it might apply, why they're doing this. So, but the discussion afterwards usually is pretty interesting. And then I'll make a parallel to whatever work they do. Like, what is it that you pay attention to? What is it you find interesting? What might not be something you pay attention to, but might actually be kind of useful to pay attention to? Can you refocus your attention? So as a family doctor, this time of year, there's a lot of flu going around. So when I'm in the office for a day, I can see, flu. I mean, there are just many, but then someone comes in and it's a little bit different. Okay? So it's, similar symptoms, but it's not quite red. It's something a little bit different. And there are two tendencies that happen. One is to say, well, this is just another case of flu. Or let's stop for a minute, let's slow down, let's look a little deeper. And maybe it's pneumonia, maybe it's leukemia, maybe it's, something else. So the parallels to everyday work, regardless of what you do, are useful.
Well, and you, talking to that a little bit further, you talk about top-down attention versus bottom-down attention, and that kind of fits into what you're describing there. I was wondering if you could just frame those two ideas and their differences for us.
Top-down attention is attending to things that you expect. So I'm going to see patients this afternoon, and I expect that many of them will have the flu, and I'll be particularly attentive to that. Or I'm driving to work, and I know there's a stop sign at a particular intersection, and even before I see the stop sign, it's already pre-programmed in my brain that this is something I'm going to have to anticipate and respond to. Bottom-up attention is the opposite. It's things that you're not expecting. So I go to the office, someone seems like they have the flu, and then they begin saying, well, I'm having this pain kind of right here. And they point to the middle part of their chest. So I could do one thing and ignore it and say, oh, this is another case of flu, or I could say, tell me more about that. Okay. So this bottom-up thing, now some things naturally hijack our attention as bottom-up. For example, a fire engine goes by and you're trying to have a conversation. It's happened to everyone, and you lose your train of thought because the sound of the fire engine captures your attention and basically short-circuits everything that was happening before. For most doctors, if patients say they have chest pain, it'll do the same thing. No matter what you were doing, you want to make sure they're not having a heart attack. So, but there are some things that should trigger our attention that don't. And, for example, depression. Depression is pretty common, potentially fatal. People do kill themselves or not take care of themselves. And yet doctors are not very good at recognizing the clues that patients might be depressed. And or something that's outside of your specialty. You're a cardiologist and someone has a mole on their forehead. You learned about melanoma in medical school. And if you saw a picture of it on a test, you'd say, oh yes, that might look like a melanoma. But sure enough, it's outside of your visual field because it's not considered salient or relevant. So knowing that, having the ability to have that bottom-up attention filter into your awareness, but not be overly intrusive, is an important skill for most clinicians and probably for most of us, regardless of what we do.
And would you say it's about balancing those two, or do you feel that one should have a priority over the other?
It depends what you're doing. So if you're a surgeon and you're focusing on a particular task, I think probably the majority of your attention is going to be top down. But there needs to be enough permeability so that bottom up things that are unexpected, actually come into your consciousness.
So you talk about a concept that you've deemed the 8 leaps, and obviously there's a lot to it, but I thought it was a very helpful and an insightful thing. So I was wondering if you could just kind of very briefly explain to us what the 8 leaps are all about.
Well, I wanted the book both to be general as well as personal. And so I wanted towards the end of the book to talk about the challenges that I face now in this phase of my career, having finished medical school over 30 years ago. So those leaps might be different for every person. But for me, relatively recently, I came to the realization that, although we're always different people in a professional context as opposed to when we're at home, that division for me was a little bit too large. And I felt more fragmented than I needed to be. And that parts of who I am at home, spontaneity, my sense of humor, various things that I tend to leave in the parking lot, just began to wonder, does this really have some important relevance to my work as a doctor? And so one of those leaps was from fragmented self to a whole self. And another one for me was a leap from empathy to compassion. Empathy is, I think, to some degree, an analytic process of trying to understand what's going on in someone else's head and reflecting it back to them so they feel that they're understood. But that's not the same degree of personal involvement as compassion would be, where you're really somehow feeling or resonating with their pain.
And I'd say a lot of people misconfuse empathy with sympathy as well, which further confuses that conversation.
Right, and these are all, because sympathy is when you kind of fall apart in resonance with someone else's distress, and that's not particularly useful in a professional context. But empathy is, but the question is, when does a patient need empathy, and when do they need compassion? When do they need understanding, and when do they need a hug? And so for me, that again is an area to explore. The issue of danger, to what degree do we make ourselves vulnerable as clinicians? How much do I reveal to patients about who I am and what I'm thinking? So the degree of transparency. You can't be transparent about everything. I'm trained so that if a patient comes in with a hangnail, I have to think, well, this could be a hangnail, but it could be cancer. It sounds kind of silly, but as a physician, you're trained always to think of, what else could this be, no matter how rare. I don't say that to a patient. It would cause undue worry. So, just how transparent to be.
Well, it's something that you go into in depth in the book that I think I found quite fascinating, because it really opens up the human side of physicians, which, coming from an outsider perspective, there's also often this air of authority behind the doctor, and you do what the doctor says. And you even talk about how it's shifted a little bit from this idea of like the doctor's telling you what to do to now a more cooperative experience, but that brings its own challenges then of, like you said, how much do you share, and do you express that you don't know, or like we don't know what the best option is here for treatment and things like that. It's really complex and challenging for doctors to sit in that space, which another reason why I think the work that you're talking about is so important, because you have to have that introspective work to really come to some of those personal answers.
I think it's very, very difficult when you're ill to deal with uncertainty. It's really, really hard. And so most of us, especially if you're seriously ill, most of us want to be told, yes, the surgery got all the tumor, or this is going to be better, or this is the best medication. But any good clinician knows that there's always some room for doubt. And I remember from early on in my Zen training, there was a saying that you needed three things to be a Zen student. You needed great faith, you needed great doubt, and you needed great perseverance. And I think all of us who are seasoned clinicians have all three of those. That you feel pretty confident that you understand what's going on. There's always this room for doubt and uncertainty. And then you need to stick with it. You need to remain engaged and involved because things change. But with patients wanting a greater role in healthcare and in healthcare decisions, there comes now the burden of sharing that uncertainty and sharing that ambiguity. So in some circumstances, I can go to the medical literature and say, yes, your cholesterol is at this level, your blood pressure is like this. If we give you this medication, it will reduce your risk of having a heart attack by 30%. And I can say to patients that, and I can't say your risk, but I think in general on a population level. But there are other circumstances in which there are two approaches, and we're not quite sure which one's better. And for some people, that's very discomforting. And sharing that uncertainty, I believe, is going to have to be a skill that clinicians are going to have to get better at, and also patients are going to have to get better at tolerating, because it's part of the equation.
So business and politics aside when it comes to healthcare, because this is obviously a charged issue on those sides, kind of leaving that for a completely different conversation, how do we grow and evolve the medical profession, other than perhaps doctors and patients picking up your book and reading it? Like, where do we go from here? Like, how do we really evolve and incorporate these ideas of mindfulness more systemically in the medical profession?
Well, it's happening, first of all, and mostly under the umbrella of stress reduction and well-being. So most medical schools now have, at least as an elective opportunity, some course or workshop having to do with mindfulness. And I would say if you ask the average physician, at least in major hospitals and academic medical centers in the U.S., if you ask them what mindfulness is, they would probably give you a reasonable definition of that. So this is really different from 15 years ago. So things have changed. I think that the opportunities for practicing physicians are greater as well. And actually, just before we had this phone call, I was answering an email from the LCME, that's the body that accredits medical schools, basically says that you can stay in business or not. And asked, they were surveying people and saying, what's really important for our next phase of accreditation? And I wrote that all medical schools really should have some way of helping physicians, in that case, because it's medical schools, be more attentive, more mindful, self-aware, recognizing that those qualities will affect the care they provide for patients, patient safety, and their own well-being and sustainability in the profession. And so I believe strongly that in addition to making sure every medical school has got an anatomy course and a physiology course, every medical school should really pay attention to the interior lives of those whom they're training. The military does this, and star athletes do this, musicians do this. And to say that doctors who hold the lives of patients in their hands shouldn't do it, I think is at this point, with what we know, is not really doing the job we should be.
Now, so much of this mindfulness training and practice can obviously help everyone in their life, no matter what it is that they do. And you're obviously a doctor, and we've talked about doctors and the medical profession. What can people, other than those elements of their life, but specifically within the medical field, when someone is a patient, what advice can you give to patients when they're going to doctors, when they're going to the hospital, and they have the uncertainty and things that you're saying? How can mindfulness help just the average person going to the doctor's office with their ailments?
Well, first of all, if it's something that is potentially serious, bring someone along with you. So you have two sets of eyes and ears, and you can process things after the visit. Because everyone's anxious when they see the doctor. And the second thing is to balance this top-down and bottom-up attention yourself as a patient. So make a list. What's most important? What's at the top of your list? If nothing else happens in this doctor visit, what do you want to have accomplished? Now, it might be really simple. It might be like an antibiotic for a urinary infection. But it also might be something more complicated, like understanding what's likely to happen with your congestive heart failure. And make a list so that your top-down attention is really focused on those things that matter the most, and you're not distracted necessarily by things that matter less. The second thing is cultivate curiosity. Okay? So even if you checked the internet and feel that you understand what's going on and feel like you know what you need, your doctor might or might not agree with you. And there might be some discussion. And so come in with a sense that you want to learn something. That whatever it is, maybe you're a health professional yourself, maybe you've got a doctor in your family, maybe you read stuff on the internet, but come in with a sense of openness. The third is to try to engage in shared mind, believing that two minds are better than one and sometimes three better than two. So try to find a common frame of reference with your doctor. So when your doctor uses a word that you don't understand or might be unclear, saying, can we just stop for a second? What do you mean by that? And when you say heart failure, what does that mean? And your doctor should be able to explain that. Do whatever it is you can do to lower your level of anxiety before you come in to see the doctor. Take a breath, make sure you're well fed. And that's part of why having someone along is really helpful. You don't have to be anxious about remembering everything because you got someone else there. And anxiety really narrows our attentional field. So those are some beginning things.
I love that. I think that those are all super helpful. Dr. Epstein, I've really appreciated and really appreciate your insights into this, and I think it's a conversation that I hope we continue to have in any healthcare fields, but in particular all fields, because mindfulness is so beneficial to everyone. Where can people find out more about your work? I know you've got a website. How can people connect to you and the things that you're doing?
The best place to start is my website, which is ronaldepstein.com. So it's really simple to remember. And there you'll see things about the book and things about workshops that I do and other publications and, pictures, the usual things you find on websites.
Awesome. Well, Dr. Epstein, thank you so much for coming on the show today. And for all of our listeners out there, thank you so much for listening. I hope you've learned something new today. I hope you all have a very present moment. Thank you for listening. Namaste. Hey everybody, before we sign off here, I wanted to let you know, if you are downloading this episode the day that it's launched or even the day after, that Dr. Epstein is going to be doing a book signing in San Diego on the 1st of February. I know we have a lot of listeners in San Diego, so Dr. Epstein is going to be at Warwick's in La Jolla at 7:30 on February 1st for a book signing. So if you're listening to this episode, I encourage you, go to Warwick's, go to La Jolla, check it out, say hi to Dr. Epstein, tell him you listened to the episode, and hopefully get his book and get it signed. Thanks again for listening. Hey everybody, it's Ashton here with an announcement. We're starting a weekly contest giveaway over at Savannah Spirit. If you'd like to enter into the contest to win one of our weekly prizes, go to savannahspirit.com/contest. If you enjoyed listening to the podcast today, we'd really appreciate it if you went over to iTunes, left us a review, leave us some comments, and share this podcast with anyone who you think might enjoy it. Also want to invite you to go check out Savannah East, which is the name of our blog and also the name of a Facebook group where I interact with guests and our audience. We'll post recent episodes up there as well as interesting articles relating to our guests and or the topics on the shows. And again, thank you so much for listening. Namaste.
You've been listening to the Savannah Podcast. To find out more about Savannah, go to savannahspirit.com or follow Savannah on Facebook at facebook.com/Savannah Spirit. For daily inspiration, check out our blog at savannaheast.com. Be sure to join us next week for a new episode, and thank you for listening to the Savannah Podcast.